What is up, everyone? Welcome back to the Critical Care Lounge. It has been a while. It's been a minute, as they say in some places. I'm going to give a disclaimer. You're going to hear a lot of this. Before anyone says anything, that is a squeaky chair. It's a squeaky chair because this is a office studio in transition. I'll talk about that a little bit later. But welcome back. It's been a while just because we've been so busy and we have not been able to line up our schedules. But I'm sorry. And I really have no other excuses. I'm joined by my always amazing co-host, Dr. Adam, the Green Machine Green. What is up, my man?
Not much, man. How you doing, Haney?
I'm doing very well. Since we last spoke, an animal has taken up residence on my face. It's been
I was gonna say I hardly recognize you. It's been so long.
I know. It's I'm trying to hide. I'm hiding from our bosses. But it's good to see you. What, Adam? Anything new that's been new and exciting in your life, clinically, or
holidays coming up, spending time with family. COVID numbers going down.
Yeah,
all things are good.
That's good. Right.
How about you?
Everything is good. I'm just hanging out, having a good time, doing my thing. And like you said, holidays are coming up. There's always a nice time of year. Always very stressful for me because I never shop until 3 days before Christmas.
Yeah.
Even though since September I've been saying to myself, this year is going to be different. As of today, December 1st, it's exactly the same.
Well, I have this strategy where I tell all my family members we're not getting presents for each other this year. We're not doing it.
Right.
And then right around this time I find out they all got a present. I got nothing.
All right. Well, then you're on the hook, my man. You're on the hook.
Here we are. So who we got today?
Well, today we have
Patel, right?
Yeah, we got the man, the myth. Let me just make sure. I want to make sure the audio is good because we got a little bit of a different setup here. Someone is saying your audio is a little soft, Adam. I don't know if you can get a little closer.
Is it? Yeah. It's
just
my
yell.
mic isn't working.
Tell
I
to
don't
your
know
family
what
that you're
to
just
do
having a
about that.
passionate conversation in there in the bedroom.
I will. I'll try to speak up.
That's all right. I'll read your lips as you speak.
I have an idea.
He has an idea.
I apologize. I'll be better.
All right, it's no good. It's all good. Let me go ahead. I'll introduce while you're working on that. Do you want me to just go ahead and introduce our guest? Get right down.
No. I got it.
You got it. Okay, let's go.
Good. So today we have Dr. Sharad Patel. How do you describe him? Intensivist, nephrologist, programmer, ultrasound enthusiast. I could go on and on. What else you got about him, Haney?
He's also just a handsome guy that does CrossFit. And you know how I know he does CrossFit? Because he tells us he does CrossFit. That's the thing. Anyone that does CrossFit, you know how they do CrossFit? They'll tell you.
Yeah. Sound like neurosurgeons.
Yeah, and vegans.
A lot of similarities.
Yeah,
and
lots.
So I'm going to tell you. Usually my strategy is to tell lots of jokes and maybe learn something. Today my strategy is silence. I just want to hear from Sharad and soak it in. That's my goal.
All right. Well, welcome, man. What's up, Sharad?
Hey, how's it going, guys? Thanks for having me on the show.
Oh, totally. Tell us a little bit about yourself and what you do. And if I ever look down, I'm not being disrespectful. Just keep an eye on the chat. But tell us what your deal is. Why you're a nephrologist, right?
Yep. Exactly. Yeah. So I did a nephrology fellowship, critical care fellowship. So work 100% as an intensivist, but a lot of my interest and a lot of my passion still lay in the nephrology realm. So research and things like that, and just basically just how can I apply the nephrology lens to the ICU? And so clinically, that's kind of my deal.
Okay, fantastic. So let's go ahead and start off. I'm getting some comments, and I do apologize about the echo. I'm going to look into it, see if we can fix it. But in the meantime, we want to get right down to it. I'm going to let Adam start off with the questions, and then I will be back with you folks.
Great. So I think the title of this episode is "Don't you dare give that fluid bolus." So explain to me fluid tolerance. Explain to me fluid responsiveness. Let's just jump right into it. What do you think about when you hear those terms?
Awesome. Thanks, Adam. These are probably topics that, like, if you were to create a drinking game during rounds, if that was an alternate universe for that, every time I say the word fluid response or fluid tolerance, there would be a lot of drinks. So I use these terminologies a lot. And Joe, basically the difference between the two is fluid tolerance. You can think about it with the concept of, if I were to give a fluid bolus to this patient, will I harm this patient? Examples of that could be that they already have pulmonary edema. They already have signs of venous congestion. They have intra-abdominal hypertension, history of pulmonary hypertension. So all these things that will increase the likelihood that if you were to give a fluid bolus, you would potentially harm that patient. Now, responsiveness is probably a bit of a more of a hotter topic. Lot of research in this in the literature. So responsiveness essentially is, if I were to give this fluid bolus, will this patient's cardiac output go up by about 12 to 15%? Right. So that's basically the distinction between the two. Now, uh, you can ask yourself is like, what is more important? Which one's more important, and which one should precede each other? My thought is that if the patient is not fluid tolerant to begin with, so if you did an ultrasound, you did evaluation of the lungs, you did an evaluation of the IVC, you have signs of B lines and pulmonary edema, you have a big plethoric IVC, that patient is not volume tolerant. So at that point, asking whether the patient is volume responsive or not, I think, is a null or mute point. If that patient is hypotensive, you should probably go ahead and proceed with pressors rather than going down the route of just further fluid boluses over and over again.
Great. Henny, are you still with us?
Yeah, I'm with you now. I'm
We
back.
got that
I
all
just
fixed.
didn't want to.
Good. Feedback
Yeah.
sounds great now. Good. Just soaking it in. All right. So we give lots of fluids. I'm trying to think. I think generally speaking, we give it in bolus format. And this is a slightly different question. When do you give continuous infusion? When do you set that 100 cc's per hour, or do you never do that? Do you only say, is this patient fluid responsive? If so, you give the bolus. If not, you do nothing.
I would say, like, 99% of the time I'm giving boluses, so at least I can control it. What I'm afraid of with the maintenance fluids is that you kind of set it and you forget it, and then 2 or 3 days later, you're up 4 or 5 liters. So I'd like to be a little bit more in control of my fluids. So I usually go with a fluid bolus strategy. Now, the only kind of like caveat to that is that if there's persistent output, so for example, if there's large amounts of stool output, that person is persistent or high ostomy output, that person may warrant maintenance fluids, because I think one of the best lines I ever heard in regards to fluids, I can't remember the intensivist who said that, but if you're going to give fluids, especially continuously, show me the bucket where the fluids are continuously coming out, right? So I truly took that to heart. So I think the role for maintenance fluids exists, but I think it should be the exception rather than the rule.
That was probably Haney who said that. Sounds like something he said.
Most quotes that I use come from Haney.
Yeah, me too.
But I don't like to give him credit for it, though.
Story of my life.
Yeah, I'm gonna use that squeaky chair one later.
That is definitely my own. That's the one thing I have come up with my own.
Sharad, I'm gonna go off script. You mentioned 4 or 5 liters up. I love that you said that, because I have no idea what the heck that means. The I's and O's, and I don't even want to talk about the accuracy of it. Let's assume it's recorded completely accurate. I never believed that a liter of free water equals a liter of lactated ringers. How do I justify that? How do I think about the I's and O's? And what do I do about that?
No, it's a great question, Adam. I think let me kind of like pose a scenario to you. So let's say you had 2 patients and you were weighing them every day. Neither of them are making urine, so it's kind of a closed box. You give one patient 5 liters of D5 water, the other patient 5 liters of lactated ringers. The second patient receiving the LR, their weight will go up. Their dry weight will go up. They'll have pulmonary edema. They'll have congestion. Whereas the patient that got the D5 water, you probably won't notice too much of a difference. And so what's the big difference? It's sodium. unless the fluid has sodium in it, it doesn't have persistent volume expanding characteristics. So free water usually is, I don't even take that into account as my ins and outs. So does that answer your question, Adam? I think that's
Yes,
it
no,
has to
that just
have
support.
sodium in it.
Yep, yep. That supports what I'm thinking. I constantly thinking, what is the difference between hypovolemia and dehydration? And they're drastically different terms, and we
Exactly.
treat them differently. We think of them differently, and I think you're right. And maybe I'm paraphrasing, but I look at the I's and O's, then I examine my patient, I think about it, and I say to myself, does these I's and O's correlate to a clinical characteristic that support the need to remove the fluid, or is it just a number in the chart?
Yep, exactly. Another scenario, kind of like probably one of the best examples I can think of, and this is probably a very common scenario, especially in the cardiac ICU. So you have your patient that you're diuresing, and they're on Lasix monotherapy. So Lasix usually outputs hypotonic fluid compared to what your blood tonicity is. So anytime the output is more hypotonic compared to your blood tonicity, your sodium's going to go up. So you're going to get hypernatremic. So how often have you guys had that issue where you're trying to diurese someone and then they become hypernatremic, right? And so the way I deal with that is actually there's a precise way to do it where you can actually do some urine calculations. But this isn't a nephrology talk, and I don't want to put anyone to sleep. But
Yeah.
if you just put D5 water in and you're diuresing them, ignore the D5 water that you're giving them. Ignore that in your calculations. Just look to see what's coming out and what other sodium solutions are going in. You will decongest that patient, even though the absolute volume that's going in versus out might be exactly the same. That patient will decongest.
And that's
Any
assuming that the person has perfect renal function that's working okay, correct? Like
Correct.
all
So
else being
that
equal for all these things that we're talking about.
exactly, yeah. If the patient has adequate renal function, that's the person you'd be talking about. So because you're still trying to diurese them. So
And
yep,
the other
exactly. They should have some renal function.
And the other thing, because I like that analogy. If you have two patients with good renal function, one's getting LR and one's getting D5, the person is going to hold the LR more. Their dry weight will be higher. However, my question is, does that translate to intravascular volume? So yes, so now they weigh more, but do they weigh more in the place that you want it to be, the intravascular space?
So that's probably a very you'd be opening up a can of worms there to answer that question, I think. But I would say if you're giving a fluid bolus of LR, or giving fluids of LR, it would depend on whether this patient is septic. Do they have capillary leak? Or is there no inflammation? So, and rarely do we have any patients that have no inflammation, right? Guys, like everyone in the ICU is inflamed for some reason or another, right? So I would say most patients that you're giving that LR to, that fluid doesn't stay in the intravascular space for very long. Healthy patients, if you give them a 500 cc LR bolus, typically that cardiac output increase that you may get, hence being in the intravascular space, usually lasts for about 30 minutes or so, right? So 30 minutes to an hour. So if you imagine someone in septic shock, you can just you don't need an exact number, but 15 minutes, 10 minutes. So it's very short lived.
Hmm. And it begs the question, and I know there's no definitive answers, but it begs the question of whether or not we should be giving patients who have capillary leak, and the sepsis patient being the classic example, should they be getting volume at all? If their problem is an issue of vasoplegia and capillary leak, then why would you give them something that would last, if we're talking about healthy volunteers for 30 minutes, arguably minutes to seconds in somebody like that, is the John Myberg said the only fluid a septic patient should receive is noradrenaline, right? I mean, that, which I think is a brilliant statement.
Yep.
But so let me ask you, if that's the case, if you know you have a patient who is clearly septic, should they be getting crystalloids at all?
So yeah, I would say there's still this debate of how much fluid is too much in sepsis or how much fluid is too little, right? So I think in general, most patients that are coming in sick, septic, they probably haven't been eating very well. They're probably the intravascular volume probably is low, right? So, and those patients, most patients can probably tolerate a liter or two of crystalloid. I don't think it causes harm, and it may provide potential benefit, but you're not going to be treating this disease process completely with fluids. I don't think about fluids as a treatment for sepsis as we've done so for so long. It's just an adjunct to help someone who probably has had very poor PO intake, maybe intravascular depleted, and at least we're ruling out the intravascular component. If you give that patient a liter of bolus and their blood pressure goes up 40, that was both diagnostic and therapeutic, saying that person was extremely hypovolemic. So
Mhm.
that giving that fluid initially, it can be both diagnostic and therapeutic. But if you're not getting a response, I would be giving
Right.
more boluses on top of that. This is why I think in general, the one size fits all um, process of giving fluids probably is an oversimplification of how different each sepsis patient actually is. And so I think in general, I would completely agree with John Myberg. I think you should reach for that levo early, but I don't think a liter or two is probably going to be harmful for most patients.
Yeah, it's funny because when I started my residency, which Sharad was back in the '60s, we weren't doing anything at all. No, no. In all seriousness, when I started doing my residency, I kind of entered into the Rivers era. And for anyone that remembers or likes nostalgia, that was like, they're not well until they swell, which means you just kept hammering them. Crystalloids, they're puffy. It's like, oh, that's great. And you use things like CVP, nonsensical measures. And then we did some more refinement through process trial and all those, the three big trials where it said maybe we need somewhere between 4 to 5 liters. And now there's newer studies that are coming out. The classic one I think was one of them, and there's a couple more that are being done. That's like you said, maybe all you need is a liter or two. So it's funny how it's coming around full circle, from doing nothing to giving Rivers dosing to less to now. I think what we're getting is we're starting to find out the right question to ask, which I think we didn't have for a long time, using things like ultrasound at the bedside and other technology. So anyway, I wanted to give you an old man's perspective.
I just
So,
love
Henny,
I love
so
that picture you showed me when you were messing around with the iron lung.
Oh yeah,
So
polio. That people are complaining about COVID. You have no idea.
what was polio like, Haney? Just
Oh man, I don't want to talk about it. I'll start crying on camera. You guys are
But
jerks.
guys, that's something interesting, right? Like, not just with fluids. You can basically look at most things that we did 20 years ago, and everything is starting to become less is more, right? Can you guys think of anything
Mhm.
that we're doing more of, like as far as treatment? Because fluids is less, antibiotics, less is more, right? The length of treatments are shortening. Ventilation, get them off the vent as soon as possible, right? Everything that we used to do is starting to become a less is more type of thing.
Yeah.
I got one. I got one. Nutrition.
Nutrition, okay. All right. I'll
Fair.
give you that. I'll give you that, Adam. You couldn't
No,
have
but
waited
it's
till
true.
after the show
So,
to mention that.
I just want to interrupt. This is great. I'm loving this, but I just want to make an observation. 14 minutes. That's the longest, right? 14 minutes, the longest conversation I've ever had with Dr. Patel before he mentioned Lasix. That was it right there.
Well, there's
That
no
was it.
nephrologist listening. If there was a nephrologist around, he would have mentioned it sooner because that's part of the code of
Yeah.
conduct.
There it
When
is.
I
That's
when
how
I
we
leave
greet each
service,
other.
I just order Lasix on every patient if Sharad's coming on. I just know it's going to happen. So
Don't forget the metolazone, Adam.
yeah, oh yeah,
Yeah.
metolazone. Sorry, yep, BID. So I was thinking about my residency and how we did it, and maybe this shows my youth, but we would give a bolus, and I would do a lung ultrasound, and I would continue to bolus 250 cc aliquots until I saw B lines, and that's so easy to teach and so easy to do. Sharad, can you give me? And we all know B lines. We all have associated with pulmonary edema. Can you talk a little bit about uh, other signs of volume overload that the ultrasound can show? I know
Yeah,
I know there's some key words there you love. So why don't we dive into that?
I think Adam, that's a great. Actually, w- the approach you just mentioned, I think that's something that most residents can pick up, right? Like for resuscitation, like if you're giving fluids, okay, it's okay if they're hypotensive and you have evidence that they're responsive, but as soon as they develop pulmonary edema, they're no longer tolerant, right? And lung ultrasound is something they can pick up relatively quickly. So I think that's a really nice strategy for most residents coming into the ICU that they learn, and they learn to be a little bit more judicious with fluids when they see how quickly that can happen in patients, right?
Right. I hope the takeaway from this isn't that B lines means pulmonary edema. That will hurt my soul, because
But
B
but
lines
Adam,
means
to
no
that,
pneumothorax, right? B lines means no pneumothorax. It doesn't mean no pulmonary edema, or doesn't mean
yep,
pulmonary edema rather.
yep.
Um,
But most likely, if you had A lines to begin with and you're giving
Fair enough.
fluids, then you
The
develop B
transition,
lines, right?
yes,
Yeah.
It's
100%.
99.9% it's pulmonary edema.
Yep. So great.
But other potential signs, so other simple tests that most people who are like moderately proficient with ultrasound is second thing they can look at the IVC. You don't even need to look at you don't need to be completely an expert with cardiac echo. If you can do an IVC exam accurately, consistently with good interperson like variation, you can see is that if the IVC is large, that tells you the CVP is likely high, right? Because the IVC is your surrogate for your CVP. Now, that tells you that there's back pressure on the kidneys, on the gut, on the liver, and that back pressure actually reduces perfusion. So if you go back to physiology, the most simplistic way to think about organ perfusion is your MAP minus your CVP, right? Your net pressure. And so as your CVP is rising, and if you have a hypotensive patient, you're actually probably reducing perfusion over time. And contributing to AKI, contributing to bacterial gut translocation, right? So gut edema. So then there's a syndrome called cardiointestinal syndrome, right? So you're contributing to more harm if you have a large IVC and you're giving fluids. If you're giving more fluid, so a large plethoric IVC is probably a good sign that you should probably stay away from fluids. Now, there's more advanced methods, so that there's Vexus, right? So there's Vexus protocol. So the Vexus protocol is a really cool, a kind of systematic way to see, all right, this patient appears to be congested, but how congested? And how much risk do they have for developing AKI? So Vexus actually is helpful in predicting which patients will actually develop AKI Vexus protocol. And it was created by um, uh, Dr. Deneau, right? So Dr. Deneau, Phil Rolla, William, and I forget the gentleman, the PhD from Montreal, his name, but William is his first name. So they came up with this protocol, and I think Rory as well. They came up with this protocol, and they basically look at the IVC. So the first question is, I'm going to look at the IVC. Is it big or not? Is it greater than 2 centimeters? If it's greater than 2 centimeters, you go on to the next step. And then you look at your hepatic vein, you look at your portal vein, you look at your renal vein. And if there's mild disease, there's stage 1. If there's multiple severe disease, so hepatic vein and portal vein has severe disease, you go on to stage 2. And then eventually stage 3 is where all 3 tests have evidence of severe congestion. So now once you're comfortable with the IVC, this might be a more precise method to assess for severity of congestion and how much this patient needs diuresis, how quickly and how urgently this patient needs diuresis. Um, yep.
Yeah, I was going to say, because I want to make the distinction in case anyone heard this, got distracted by my squeaky chair. The Vexus is the reverse of what most people are using the ultrasound for, because most people are looking for someone that says this person needs volume. And what's nice about Vexus is it's probably asking a better question, is which patient should you avoid volume on? And an additional benefit, and correct me if I'm wrong in any of this, is that when you have a patient who is in that plateau phase of their illness, who's now recovered, who's stabilized, which patients you ought to be diuresing aggressively, because now there's evidence of organ congestion. And, I think the first study that Andre Deneau did was they found that delirium was associated with, or maybe it wasn't the first study, but they found that delirium was associated with fluid congestion because of all the back pressure and the edema, cerebral edema. And so, I just want to make that distinction that, when we're talking about ultrasound IVC and looking at the heart, and all have their limitations, that's looking for the permission to give volume. And what you're doing with Vexus is you're saying, I think this person probably has enough, or I'm trying to figure out if I want to get fluid off. Is that right?
Completely.
Okay. All right. Cool.
Yeah, I find that just brings a lot of clarity to the situation too, because I see people obsessed with the IVC and use it as a single point, and they, it's the same. They're using the ultrasound to look at the CV or the IVC, yet that same patient has a right IJ and they're not monitoring CVP. So I've frequently asked, we don't use CVP because we don't trust it. So why are we using a surrogate for something we don't trust?
Right.
But in the description that it's just one point of many, that brings a lot of clarity to me.
Yeah, the whole CVP issue I trained in emergency medicine and internal medicine, and emergency medicine was one of the first disciplines to use ultrasound in a point of care way. And what they found was, IVC at that time was, you use it as part of your protocol to see if they're when they were in shock. But what evidence has shown, like you said, is that CVP is not a good correlate to fluid responsiveness. And if you're going to say that your IVC in the spontaneously breathing person, right? I don't know if we're geeking out too much on this. I can talk days about this, but I'll keep this point short. But if we're saying that the IVC estimates CVP and CVP is not very good, then why are we using it in the first place? But to bring it all back to what we're talking about, I still think the IVC is a good first check. For me, when I go to see the patient, I put the ultrasound probe on. If the person's hypotensive and the IVC is just paper thin, like I can't even find it because it's so thin, I'm like, this person probably needs fluids, but even if they don't, I'm not hurting them. And if the IVC is big and juicy, then I start to think about the things that Sharad is talking about. It's, it might not, they still could be volume down. They still could be total volume down. However, giving that person volume in the venous system is not going to help the situation anymore. You'll have to figure out why there's an obstructive process there that's blocking the blood from getting to the right heart, or what the other process is. So that's kind of my very simple algorithmic approach when I'm going to see a patient who's in shock.
Completely agree. I think it's just that if you have a large IVC or a high CVP, you're essentially saying there's RV dysfunction of some sort, right? So you're saying that the RV can't take any more fluids, that it just can't. And if you were to expand on that, the RV LV ratio is probably going to be changing if you're going to keep giving fluids, making the RV bigger, making the LV smaller, and you may even potentially drop their cardiac output at that point. So I think a CVP is really just a marker of how much your RV can handle, and are we already past the line where they can't handle anymore?
Yeah, I've definitely come full circle with it. I think, I used to like when they put the CVPs up on the monitor, the nurses used to tell me, I was like, CVP. But now it's just one more vital sign that if you're doing something right and your CVP is high and your CVP is starting to come down, actually tells me that I'm doing something right to move things forward through the heart. Anyway, I've hogged up the mic enough. Adam, what do you got?
Oh, geez. Can we talk about the lungs in some way? Something about oxygen. I'm a pulmonologist. This smart doctor talk is hard on me.
I just want to point out that you both are nerds, both of you with your subspecialties, pulmonologists and nephrology. You don't need that to do critical care, folks. You don't. Yeah. But go ahead, talk about oxygen, pulmonologist. Go ahead.
I feel like I should tell my joke. Here's my joke: is ID or thorough docs, nephrologists or smart docs, and intensivists were just available. We're when you don't know who to call or there's no one who will show up, you just call the rapid response and you get like 12 of us. I like so tell me about and creating the script for this talk. I want to bring it into VO2 responsiveness. I want to talk about oxygen delivery, because really the goal is never to make my SAT 100% or to make my MAP 65. The goal is, can I get enough oxygen to the tissues, the distal tissues? So I'm sure you got a rant about that. So hit me with that.
I definitely do. Yeah, it's one of those things where this has also been a progression of my understanding of what to do and what the end goal of fluids was, right? Initially, when giving fluids, I kind of just blindly gave fluids. Then I learned about volume responsiveness and volume tolerance, and I was thinking, okay, volume responsiveness is the endpoint, and I learned it's actually not. I thought about oxygen delivery. Okay, so in the end, I was saying, okay, it's all about oxygen delivery. Taking it one step forward, you can deliver as much oxygen as you want, but is the body consuming more oxygen, right? Is there a reduction in oxygen consumption? So in sepsis, truly, it's not usually not an oxygen delivery problem. Like, you can do the math on it. If you looked at the oxygen delivery equation, right? So the main components of the oxygen delivery equation: cardiac output, hemoglobin, and oxygen saturation, and PaO2, but it's such a small part of it, you probably don't even need to think about it. And you think about those things, and if you actually plug in numbers, it's extremely low values that lead to a point where your body actually starts reducing its oxygen consumption. So it's usually not a reduced oxygen consumption, and it's usually not a problem with not delivering enough oxygen. Now, there is a critical point where your oxygen delivery can drop, where your oxygen consumption drops as well. Those are the patients that you probably should be trying to increase their cardiac output, either through fluids, inotropes, some sort of method that we do on every other patient. But I think it's of questionable benefit for most patients that we're doing that on. But these patients that are VO2 responsive, that they've fallen off that cliff where the oxygen delivery is so low that the oxygen consumption has dropped. So they're called VO2 dependent patients. And those are the patients I think that we should be aggressively trying to increase oxygen delivery.
So how do you figure those people out? Can you know, I mean, that's nice. That's nice for like where all the nephrologists hang out in the lounge and talk about that stuff. But like at the bedside, how are you doing that?
How do you find that, right? So that's actually a magic question. There's one, when I was leaving fellowship, the new vents they were getting, it actually would calculate VO2 for you. So a study I was thinking about was doing passive leg raise, assessing for VO2 responsiveness, and because it actually had a metabolic cart hooked up to within the ventilator itself, which I thought was awesome. And that's one way, but not all vents have that. The best method that I've seen in the literature, and it's something that it's extremely fascinating. So uh, I have to start with the respiratory quotient. I'm going to be very short with that, but the respiratory quotient, right? It's just basically the ratio of oxygen production over oxygen consumption, right? So let's think about that ratio for a second. Usually that's about 1 to 1, right? You use oxygen and you produce carbon dioxide, right? So that's usually 1 to 1. Now, when there's evidence of actual reduced oxygen consumption, that respiratory quotient rises. And so there are surrogates that we could probably easily check if you had a central line or swan or something like that, that actually are surrogates for the respiratory quotient. And what studies have shown is that if the respiratory quotient surrogates and that ratio goes up above around 1.6 or 1.7, that has it's almost like a perfect test to identify the patient that's VO2 responsive. And how do you do that? So one way to actually get that surrogate, so one surrogate is basically you're trying to get the difference between your venous carbon dioxide and your arterial carbon dioxide over the difference between your arterial oxygen and your venous oxygen. And that ratio is your surrogate for your respiratory quotient. And you can do that using drawing blood from a central line, right? Checking mixed venous and things like that. So that can be done. But that's probably the best test you can do to find that patient that's VO2 responsive. The next best thing is what they found was if the lactate was greater than 4, that had a decent likelihood ratio, meaning like if that's present, uh, how often how often is that lactate, if the patient is VO2 responsive, how often is the lactate greater than 4? And so that was a decent test. It's not great, but a lactate greater than 4 may be helpful to identify a patient that's VO2 responsive.
All right, so I roll up next to a patient. I just want you to walk me through what you do when you walk up to a patient. Let's just say there's no ultrasound, or you've done your ultrasound, you're still not sure. So now you're going to the best test. How do you do it?
So the best test, I would probably say, is the surrogates of the respiratory quotient. So if I had my central line,
Mhm.
I would be just basically drawing a blood gas. I would go an arterial blood gas, and I would be
Mhm.
doing a mixed venous blood gas. And I would take the surrogates of the carbon dioxide and oxygen both and just subtract, and then you get your ratio from that. And
Okay.
so that's essentially what you do. So you're just trying to get that ratio, and both those two simple tests will help you get the carbon dioxide content and the oxygen content from both the arterial and the venous side.
And just so everyone's on the same page, I want everyone to be clear about this. We're talking about central lines that are either subclavian or internal jugular. They have to be, sampled from the right atrium, right? We're not talking about femoral lines.
Exactly.
Yeah. Okay. Okay. It sounds simple enough.
Yep.
What do
Yeah,
you
I
think,
think I
Adam?
think that's the next level. I would be I I don't think I do that consistently enough because that is an extra step that's involved among. So I think oftentimes we have too much data and we kind of get kind of in the weeds with all this data and we get confused with all this data. If I could reduce a lot of these other tests that we're doing and just focus on the things that we actually know actually work and make this more standardized, I would probably use this test a little bit more. But I don't use this consistently enough because I just it's just not standard of care yet. And the concept really still isn't understood. And when I'm speaking this language, it's not something that's usually something that most people use and understand yet.
If there was only someone we knew who had access to data sets and can create calculators based on artificial intelligence, if we only knew someone like that, it would seem such a calculator would be easy to make.
That's the next step, Annie.
All right. Nice.
Yeah, I'm gonna have to re-listen to this lounge because I'll admit that I myself am struggling a little bit with this. So so tell me how LV dysfunction works into this scenario. Does it
Yeah.
change it at all?
Yeah. So the LV dysfunction, how would it be? You would basically saying is if your cardiac output is low enough and your oxygen saturation is low enough indirectly through the pulmonary edema, your oxygen delivery will eventually drop, right? It can drop to a critical level where below that critical level, your oxygen consumption will drop. So theoretically, someone with cardiogenic shock may be VO2 responsive if their cardiac output is low enough and they're hypoxic enough to drop off that critical level.
Okay, I'll buy it. I'll buy it.
That's the thing about nephrologists, I gotta say though. They talk a good game and then they talk you into circles, and then at the end you're just like, mercy, it sounds good. Just
I'd like to disagree with you there, Henny, but you're completely right.
Usually when he wants to confuse me, he just says Bayes' theorem, and I go, oh.
That's another thing.
It's true.
No, it's true. That's another thing. Someone should count the number of times I say Bayes during rounds.
Actually,
at least
we have a game that we do a little shot every time you do, and then I usually just have to go home. I don't. That's a lie. I never drink. That's a lie. I drink a coffee.
You probably wouldn't be standing after that game. How often I use the term Bayes.
A lot of the residents actually think you're talking about Beyonce every time they say Bay, and they're like, "Oh, this guy's cool." Put a ring on it.
I wish I was cool enough to be referencing Beyonce when I'm saying the word Bay.
Well, some people think you are, so just so you know. Well, I don't know. We were going to get into Bayes' theorem and pre-test and post-test probability, but I think we threw a whole ton at the people. And I don't know. Is there? Do you want to go into it, or do you think we're good? Because I feel like we addressed the issues of fluids, which people like to talk about. What a bolus matters, how to assess a bolus, how to assess if a person's too volume overloaded, and a novel way of assessing whether someone is in need of a volume bolus, which I think is really cool. I think that's a good session. But
Definitely.
What do you think, Sharad? Anything else that you want to add with respect to that?
No, I think like with it's for all like trainees listening, I think everyone should learn about Bayes' theorem and how it applies to medicine, because I really think it's probably the best systematic mathematical way to come up with the right diagnostics, the right diagnosis, without going down paths of useless tests. I feel like if you know Bayes well, Bayes theorem well, you can apply it. You probably order less tests, and your outcomes are just as good. The last thing I'll say about that is using kind of like simple Bayes math. Um, I found that the probability of VO2 responsiveness at 2 hours of all comers to the ICU is probably around 10%, right? So if you're saying is that someone just, if you're seeing all comers, only 10% of those patients are going to be VO2 responsive. I'd really, really question that why are we doing a treatment like giving fluids if only 10% of those patients are going to be fluid responsive, right? So like it's just, we don't do treatments that only work 10% of the time, right? What treatment can you name? So I think Bayes can help highlight that.
Shoot. Hang on a second. Sorry about that. That's how many times you said Bayes theorem. It was 13, but you kept talking, and then we went to 14, and you wouldn't stop. And there it is, 15 times you said Bayes.
And then you ran out of room on the paper, so we just...
There's no more room, otherwise... Yeah. And then there's puke emojis in the comments, in the thread, so...
I don't blame you.
Just saying. Well, you got now, and you also got to talk about Bayes, so you got to talk about everything you wanted to talk about.
I'm happy.
All right, good. Let me take some questions from the audience here. This is usually what we do at the end of the show, just to make sure that everyone got their... besides all the audio issues, which I appreciate, Rachel, who's from Cooper, says, can you only rely solely on CVP monitoring when you don't have immediate time to ultrasound? So if you don't have time to ultrasound, the machine is away, or maybe you don't know how to use ultrasound. Can you just get away with just using CVP?
Yeah, CVP is what we're trying to figure out when we're doing the ultrasound, right? So you have your gold standard test right there. So if you already have a central line and your CVP is consistently showing 18, 20, I would argue you don't need to do the ultrasound. Like your Vexus score is going to be high. Your IVC is likely going to be plethoric. You're probably going to have intra-abdominal hypertension.
However, however, that's assuming that you know exactly why that person is in shock. And I would argue that you would do the ultrasound because your CVP could be elevated for a variety of reasons that you haven't yet identified with.
100%. Yeah, I think I probably led to this just the oversimplistic view of just the venous side. So if you're trying to figure out...
Yeah.
Exactly. Yeah. But you're completely right. And like, if you're seeing a CVP high, that's high, you need to figure out the etiology, right? Mm-hmm. But if you're trying to figure out if I'm going to harm the patient or not by giving a fluid bolus, or you're wondering this person has AKI, why do they have AKI? The CVP of 1820 can go in and tell you that there's something wrong, there's congestion, and you should probably avoid fluid, maybe start diuresing that patient. But yeah, to find the etiology, you will definitely need ultrasound.
Yeah. Yeah, and I think the next generation, even though the three of us are very comfortable using ultrasound and like using ultrasound, I still think our contemporaries, if I could be part of your age group just for this discussion, don't use ultrasound routinely. But I think the next, like the medical students, I don't have a butterfly that's like within arm's reach here, but they're getting them as like graduation gifts from like going to medical school. So the age of ultrasound is really here, and to say that you don't have ultrasound, don't know how to use it, I think that's something that it'll be like I can't work without my stethoscope. This will be the equivalent of that. Like, how could you assess a patient without an ultrasound?
Definitely, and that's how I feel today. I think it's like, why are we still using a 200, 300-year-old piece of equipment? I won't start that rant though, but I have a rant about the stethoscope.
I'll start that rant. I'll start it.
As long as you don't say Bayes, you can talk about whatever you want.
Yeah, that's right. I'll make the plug that the stethoscope has never been correlated with improvement in outcome. However, the ultrasound has. That would be my one statement. So tell me, what else do we have? We should, I guess,
we have one. Thoughts on central venous pressures and static markers of cardiac preload for predicting fluid responses. We kind of already spoke about that, but you know, any thoughts? Because for those of you who don't know the term static pressures versus dynamic pressures, when you're looking to volume assessment, static markers of volume responsiveness would be things like a CVP. You look at something and make it determine kind of binary. It's like they need fluid or they don't need fluid. Dry mucous membranes, I guess, would be, or urine output. Those are like static markers. You're looking at something and you're making a decision. A dynamic marker, you mentioned one of many, which is passive leg raise. You're doing a test to ask the question, and based on the results of that test, you're going to make a determination. So, any thoughts on that, Sharad, in terms of like static volume markers for CVP?
No. I mean, I think static is probably the non-experimental way, and like dynamic is an actual experimental way that you have this test, you have your hypothesis, you actually doing intervention like a passive leg raise, and you're seeing what the results of that experiment was, right? It's more of the scientific method in action.
I used to call it the art and the science of volume assessment. Like the art is, well, because you're not going to not look at someone's mucous membranes. Like if you see the CVP on the marker, you're not going to not look at it. But that leads you to do the scientific test, which is kind of what we do, right? You have a hypothesis, and I think that all those static markers give you the hypothesis, and the science is actually doing those dynamic markers.
Definitely.
See how eloquent that was? Was that eloquent? No Bayesian. No Bayes was mentioned in any of that, just so you know. And then someone named Sham, who if you know, I think is just picking on me, saying an overview of the basics of Bayesian theorem would be awesome. And I'm just I'm going to turn off your microphone if you answer that question. Someone is asking about art line variability and volume time integral, post-fluid challenge, just kind of other markers, I guess, for volume assessment. Do you do any of those?
Yeah.
Like, do you use VTI and pulse pressure variation or stroke volume variation on your A line?
Yeah, I love VTI, right? The LVOT VTI is a surrogate of your stroke volume. And that's your actual test of measure, right? You can't do a dynamic measure unless you've identified the test or the test that you're using, right? So if you want to do a dynamic measure, you're doing a passive leg raise, you have to identify some means of identifying flow or something that's a surrogate of flow. So LVOT VTI is a surrogate of flow. And so you could also use a non-invasive cardiac output monitor that measures area under the curve of the arterial line, right? So there's a lot of methods you can use, but you have to identify that test first, and then that intervention happens. You need both those things to actually do dynamic measurements. But I use LVOT VTI a lot. And actually really nice, one of the things that I think are usually on the first day, when I have a hypotensive patient, I think if you do an LVOT VTI and you have a high LVOT VTI, it's essentially saying you have a normal to high heart rate, saying you have a normal to high cardiac output. That essentially rules out 3 types of shock, right? You've ruled out, like it's antithetical to the definition of hypovolemia, cardiogenic shock, or obstructive shock if you have a high cardiac output. All that leaves is distributive shock. And what's the most common cause of distributive shock? Is septic shock, right? So you've essentially, with one test, potentially ruled out 3 types of shock. So I think that something like LVOT VTI, learning that and learning it well, it's difficult at first. There's a huge learning curve. If you don't have that option, you don't have those ultrasound skills yet, something like a Vigileo, a non-invasive cardiac output, like a Nikon monitor, these things are more and more available in the ICU. So I think something like that would be very helpful.
Phenomenal. Adam, what else you got?
I got nothing. What do you got?
All right. Adam, Sharad, I appreciate you coming on. Honestly, it's you're like one of the nephrologists that we've let into our inner circle in the ICU. But I always say that you're the nephrologist that doesn't really admit that his one. Like, it took me a long time to even know that you were a nephrologist after knowing you.
I just, I try to keep it on the DL a little bit, but but thank you for having me. I appreciate it.
Yeah, man. Anytime. We'll have you on again. Take care.
Thanks, guys.
Adam, that was fun. Now, I don't want anyone to mishear. Let's put a little music on here. Let's set the mood. Make sure that we get this. Can you hear music? Can you hear any music there?
I can hear music.
Adam, do you hear any music?
Yes, I hear music.
Good. Set the mood. This late night DJ thing. Honestly, it's nephrologists are super duper smart, and I thought I was going to do nephrology. I was doing EMI, and for a moment, just a slight moment, I think it was post-night, I was thinking I thought it would be one, because they just have such an overwhelming understanding of physiology. It's truly amazing. But you take a physiologist, you put them in the ICU, and I think you have a perfect position. Followed by pulmonologists, okay? So
There we go.
Thank you. Just let's be clear with that.
All right, guys, I'm going to go destroy Finn in chess.
All right.
All right.
I'm not holding back. Just because this is the second time he's ever played. He's getting destroyed.
Never. With kids, I don't know if they can hear the audio, but Sharad's going to go play his son in chess and is not holding back. And as I've always said, when you have kids, destroy them in any sort of games, whether it's physical games or challenges. There's no participation trophies. That's how they want to play harder and win. If they can beat you, then they're like, why would I play my friends at school? I beat my dad.
Exactly.
That guy's supposedly smart. Beat him every time.
See you guys
later. So Adam, I did have an announcement that I don't even know if you know about this announcement. It's so new and I'm so excited about it. Would you like to hear it?
I do.
Okay. So starting on January 1st, so that is in 30 days, we are going to have a new studio that we're going to be in. A live studio where
Are we going live?
Yes, there won't be this bar between us anymore. We're going to be in the same studio, sitting next to each other, or maybe like 6 feet apart, depending on how the world is. But we're going to be in the same spot, in lounge chairs, doing the show, which is something that we want to do from the beginning, but we finally have a space now to do it.
But wait, you had me buy all of this equipment, which didn't work. Does that mean I don't need it?
You can bring it if you want, but we'll have other equipment there too. It's good
no,
to have there. But we're going to have the whole space set out. It's going to be decked out. And this is the part I like the best. The space is actually big enough that we will start, when it's safe to do so, we're going to have a live audience there with us. So we'll be inviting residents, fellows, attendings, first come, first serve. We'll have some food. We'll have a little hangout session. I have big plans for the space. It's a big space. But starting January 1st, we're going to be in a physical space, and then when it's safe to do so, we'll start bringing people in, and then it's going to still be a live show over the interwebs, but for a group of people that can get in there, we'll actually be doing it live.
We're going to have to plan a good episode then.
Yeah, or we can just hang out and we play cards.
Oh, you want to do a hangout episode? We'll do a hangout episode.
Yeah, it's going to be great. It's going to be great. Trust me on this one. The studio space, trust me, it's going to be good. You're going to like it. And it's not far from the hospital, so we can just pop in there and work anytime we want. So just wanted to let you know about that. That's coming up very soon. And then other than that, if you are interested in, well, first of all, let me just say this. We should have said at the beginning, I want you to go to that button on your phone or on your computer and hit the like button and then subscribe to the channel. That helps the algorithm, helps more people see this. And most importantly, just shows your support. And we have a lot of people on here tonight. I'm very grateful for you all for taking time out. But go ahead, hit the like button, subscribe to the channel, and we promise you that we are going to be more consistently coming out with this. Our plan right now is to do a minimum number of shows, 2 per month every 2 weeks. And that's something we're going to keep to moving forward. And then as we move forward and as we get our schedule requests in and then we start to get more topics, we might even move to sooner than that.
Love it.
Awesome, folks. Adam, any closing thoughts? The studio thing blew your mind. I blew every idea out of your head with that.
Just processing.
I know. It's going to be amazing. And it's right next to a huh?
And you promised me a mug, so I'm expecting a mug there.
There will be a mug. And actually,
that's
I have
really all I care about.
A robe as well. I figure if you're going to do a show about lounges, you need a chair, you need a comfy robe that you put yourself into. I don't have slippers for you yet, and a mug. And then we'll just sit down and we're going to just have two guys having a conversation about critical care.
Sounds good to me.
All right, awesome. All right, folks, thank you so much. Again, don't forget to hit the like button, subscribe, and we will be back with you in 2 weeks. 2 weeks, I promise. 2 weeks. We will be back on here with another topic that we will announce soon. We're going to be better about announcing it so you can start planning your weeks, seeing if it's a show you want to watch, and get it on your calendar. So look for that this week. We're going to get it on your calendars. With that, my name is Haney with the Green Machine.
Green Machine.
And we will talk to you real soon.